7 years stay in the UK, he came back to Pakistan in 2020 and is currently working in Shifa International Hospital, Islamabad. His special academic interests are non-invasive respiratory support for newborns, preterm nutrition, and neurometabolic disorders. So over to you, sir.
Thank you, Said, and thank you for a very kind introduction. Should we start or should we just give another couple of minutes for people to join in?
Sir Junaid, should we start now? Sir Junaid, आपको आवाज आ रही है?
Yeah, yes. I think we can start and then people will join. Don't worry. Start, I think.
Thank you. When I spoke to Said about the topic of my talk, we decided that I'll be talking about sodium homeostasis in neonates. And when I started making my presentation, I thought that probably the title should be sodium and water homeostasis, because they both are very, very closely linked to each other when we talk about sodium homeostasis in newborns. And to be even more precise, probably the title should have been sodium, water, and weight homeostasis in neonates, because all these things are so closely interlinked with each other that when we are assessing neonate with respect to sodium or fluid balance, all these things, they have to be looked together in any clinical context, and only then we can find out that what's going on with a baby in terms of sodium. So all sodium, water, and weight, they all go together, and whenever we're doing a clinical assessment of a neonate who has abnormality of sodium, these things have to be looked together, and that's what I'm going to explain in my today's talk. So the objectives of today's talk is that we'll discuss that how neonatal kidneys, they handle sodium and water in both preterm and term neonates. We'll talk about background pathophysiology, and then we will, the talk is then divided into two halves. The first half will talk about hyponatremia in term and preterm neonates, and then hyponatremia in term and preterm neonates. I think it's very important to understand that how neonatal kidneys handle the sodium, and I'm sure we all have seen this diagram. Most of the sodium is reabsorbed from the proximal convoluted tubule, and then the remaining 25% in the thick ascending limb, further along the distal convoluted tubule and the collecting ducts, and only less than 1% of the sodium is actually excreted in the kidneys through the urine. But when we talk about the preterm kidneys, the tubules are so immature that the sodium excretion rate is very, very high. And this is the diagram which shows that the more preterm the babies are, higher is the sodium excretion rate. So you can see at about 26 weeks gestation, the baby is excreting almost 250 micromillimole per kg per hour. So that's a very high sodium excretion rate. That's the fractional excretion of sodium starting from 26 weeks. And you can see, compared to the term babies at 40 weeks gestation, preterm babies at 26 weeks, they have a much higher fractional excretion of sodium. You can see about 6 to 7% of the sodium is excreted into the kidneys. And that's why the preterm babies, especially those who are extreme preterms at 23 to 24 weeks gestation, in the first few days, they tend to lose a lot of sodium through the urine, and which needs to be replaced, and that needs to be considered in their fluid management. So that is an important difference between the preterm, especially extreme preterm babies, and the term babies, that in preterm babies, the renal tubules are so immature that they're losing lots and lots of sodium, and with that, they're also losing the water as well. This is another diagram which is again explaining, this is at the age of 2 weeks at various gestations, that how much sodium is being excreted in the urine. And you can see that compared to 30 weeks at 23 weeks gestation, the sodium excretion is almost 2 to 3 times than what is at the 30 weeks. And for term baby, if we compare it with term babies, it is probably 8 to 10 times higher at 23, 24 weeks gestation. So that is a very key difference in terms of sodium handling between the preterm and term neonates. And that should affect our decision making when we are managing fluid balance in extreme preterm neonates, that the kidneys are not able to handle sodium very well, and they have a tendency to lose sodium in the urine. Now, another important concept which is important to understand is that the neonatal kidneys, or even kidneys in adults, they cannot get rid of water on its own. They do so by losing sodium in the urine, and then water follows the sodium. So the water and sodium, they go together in the urine. I think it's also important to understand the neonatal water balance between term and preterm babies. So you can see that in term babies, the total body water is 78%, out of which extracellular is about 44% and intracellular is 34%. But if a 24-weeker, you can see is about 86% is total body water, out of which majority is extracellular and about half of that is intracellular. So that is again a key difference, that for very extreme preterm babies, the majority of their body weight is composed of total body water, and that's why it affects their sodium homeostasis as well. This is a diagram which shows that how water content changes during the fetal life and during the first few months of life, and you can see that in the fetus, especially, you can see at about 12 weeks of gestation, about 92% of the fetal weight is water. And as the pregnancy advances, this decreases. At 24 weeks, this is 24 weeks, you can see that still about 86% of the fetal weight is composed of water, majority of which is extracellular. But as the pregnancy advances, the total body water slowly decreases, and that is because of the reduction in extracellular fluid. And at term, you can see about 74% of the total weight is water. And after birth, there is then gradual reduction in the extracellular fluid, and that is because of the diuresis that happens straight after birth. After about 24 to 48 hours, the baby starts passing urine, and then there's further reduction in the extracellular fluid, and there's further increase of the intracellular fluid. So more extreme the preterm babies are, I think this is important to understand, the majority of their total body weight will be composed of water. So another important consideration when we are discussing fluid balance and sodium homeostasis is the degree of insensible fluid losses, because along with the fact that majority of the body weight is water and their kidneys are immature, they can't handle the water, they're losing sodium and water in the urine. Another important factor in extreme preterm neonates is that because their skin is so immature, the degree of insensible fluid losses is huge. So on this diagram, you can see between 25 to 27 weeks gestation, the neonate is losing almost 125 ml per kg per day of water just through the insensible fluid losses. So that's a significant amount. But if you compare that even with the 28 to 23 weeks, it's almost half of what would be at 25 to 27 weeks gestation. And as we move closer towards term, the degree of insensible losses is then much less. So compared to, I mean, this graph doesn't show 22 to 24 weekers, but I'm sure that the degree of insensible fluid losses among those is even higher, maybe up to 150, 160 ml per kg per day. And in term babies, that is much less. So this degree of insensible fluid loss again directly affects the sodium homeostasis and the sodium levels, and that we'll explain further when we discuss hypernatremia. So when we are assessing the fluid status in a newborn, there are few factors that need to be taken into consideration. And the most important, as I explained, is that what is the gestation at birth? How preterm is the baby, preterm or term? And if the baby is preterm, whether it's how extreme preterm the baby is. So that's a very important consideration. Second, what is the current clinical status? What is the clinical background? What's going on with the baby? Otherwise, the clinical examination, and then what have been the recent changes in weight, whether the weight is going up or whether the weight is going down, and then the fluid balance, and that what has been the input, output, and then obviously urea and electrolytes, sodium, potassium, urea, and creatine. So all these factors, they need to be taken into consideration when assessing neonates fluid balance. Another important concept when we discuss hypernatremia and hyponatremia and their complications and the complications of rapid correction in both conditions is that water will always move from the side of where there's lower osmolarity to the side with higher osmolarity. So this is a very important concept to understand, that why the complications occur when hyponatremia and hypernatremia is treated rapidly, that the water will always move from lower osmolarity to the higher osmolarity. So moving on to hyponatremia, which we will discuss first. The sodium level less than 130 to 135 is classed as hyponatremia. We can further categorize it into three types: mild, moderate, and severe. And the mild is when sodium level is between 130 to 134, between 120 to 129 is moderate, and less than 120 is severe hyponatremia. Now, there are two reasons why the sodium level will be low in neonates, and they're very easy to understand. Either there is too much water in the body, or the baby is losing too much sodium in the urine and stool. So in terms of the etiology, these are the only two possibilities which will cause hyponatremia in a neonate. So fairly easy concept to understand, and that either the baby has too much water on board, or the baby is losing too much sodium in the urine or in the stool. And once we decide that which one of these categories the baby fits into, then we can tailor our further management accordingly. So there's a question, maybe we'll answer the questions at the end. So the conditions where there's too much water in the neonate, in these conditions, the weight generally will go up. And we see that in babies with before the onset of diuresis in the first 24 to 48 hours. We all know that the babies, they don't pee very much in the first couple of days. So during that period, the sodium tends to be on the lower side. And that is one of the reasons we don't add sodium into the IV fluids until the baby has started passing urine. Any condition which causes SIADH, like babies with hypoxic ischemic encephalopathy. I'm trying to minimize this. So the other conditions which would cause edema in a neonate, like sepsis, DAC, multi-organ failure, NEC, cardiac failure. So these are all the conditions where a neonate will become edematous most of the time, because their kidneys are hit due to multi-organ failure, due to sepsis, due to DAC, NEC, cardiac failure. There's too much fluid, and if there's not enough fluid restriction and the baby is still receiving the normal amounts of fluid, then the sodium will be low. And in all these conditions, gradually the weight will keep going up until the fluid restriction is started. And then the other reason why the sodium can be low is, as I explained, where the baby is losing sodium either in the urine or in the stool. And in all these conditions, the weight will go down. So as I explained in the beginning, all preterm babies, because they don't have mature renal tubules, as soon as they develop, start diuresis, they will pee out sodium and water both, so they will become hyponatremic. Similarly, if the baby is on diuretics due to congenital heart disease, or sometimes some babies with chronic lung disease are on diuretics, they will cause hyponatremia as well. Babies with adrenal insufficiency, as we know, like congenital adrenal hyperplasia, they will lose sodium in the urine and they will become hyponatremic. Then there are a number of renal tubular defects which will cause hyponatremia, like Barter, Gitelman, and many other renal tubular defects. And similarly, obstructive uropathies also cause some degree of tubular dysfunction and would cause hyponatremia by losing urine, sodium in the urine. Another important consideration, which is not very common, but we do often may come across congenital diarrhea syndromes, like patients with congenital chloride diarrhea, congenital sodium diarrhea, where they're losing huge amounts of sodium in the stool and they become hyponatremic. So these are the two different groups of disorders which will cause hyponatremia. In one condition, the weight will go up, there will be too much water in the body, and that will cause hyponatremia. And in the second condition, there is too little sodium in the body because it is being lost in the urine and in the stool, and the weight will go down in this condition. Both the groups have different etiologies and both have different management. Another important aspect when discussing hyponatremia is that whether it is acute or whether it's chronic. The acute is when it has developed very quickly over a period of less than 48 hours, and chronic is when it has taken a bit longer than 48 hours. Next, we will discuss that how we can what is the pathophysiology of hyponatremia. So basically what happens, as I explained in the beginning, that the water will always move from lower osmolarity to the higher osmolarity. So when there is hyponatremia, especially if it's acute hyponatremia and the regulatory mechanisms have not yet kicked in the brain, the water will move from the extracellular compartment into the cells, and that would cause acute cerebral edema, and that would manifest clinically as lethargy, seizures, altered consciousness, reduced CCS, seizures. And if the hyponatremia is acute and severe and is untreated, then that would cause severe cerebral edema in a neonate. But this is more so for if the hyponatremia is very severe, especially if the sodium is below 120. Generally, we don't tend to see severe cerebral edema if there is mild to moderate hyponatremia. So what happens that when there is acute hyponatremia, you will see from this diagram that the water will start moving from the extracellular compartment into the cells, and that would cause cerebral edema. But in chronic, if the hyponatremia is long-standing, then there are certain regulatory mechanisms in the brain which can kick in, and the degree of cerebral edema is not as severe as we see in acute hyponatremia. So, as I explained, if the hyponatremia is severe and it is untreated, and especially if it is acute, then the babies who would have clinical signs due to cerebral edema like lethargy, coma, seizures, and these seizures would be refractory to anticonvulsants until and unless the underlying metabolic derangement is corrected, the seizures will continue. We are unlikely to see these symptoms with mild to moderate hyponatremia. These symptoms are more seen when the hyponatremia is very severe, especially when it falls below 120, 115. The next, if we have a neonate with hyponatremia, how do we assess? And as I explained earlier while discussing fluid assessment, the principles remain more or less the same, that we look at the gestation, we look at the background clinical picture, clinical examination, the weight is important, the urine output is important, and then obviously the electrolytes are important. So we need to have all this clinical and physical examination findings and laboratory findings to make initial assessment about the cause of hyponatremia and then to plan the further treatment. I think the management principles again are fairly straightforward. We have to treat the underlying cause, whatever is causing the hyponatremia. Now, if there is evidence of fluid overload, as I explained before, that if the baby has evidence of sepsis, multi-organ failure, heart failure, DIC, NEC, then, and if the baby is swollen, then you have to restrict the fluids. And the degree of fluid restriction is guided by the renal function, by the urine output, and by other hemodynamic measurements, that how much fluid restriction you would do. In some babies where there is severe degree of acute renal impairment or renal failure, and this urine output is very low, or the baby's oliguria, you might have to go down to 40 to 60 ml per kg per day as well sometimes. If there are any medications which are contributing to hyponatremia, if possible, we should avoid those medications. And I think this point is very important. And as I explained earlier, that all extreme preterm babies, because their renal tubules are immature and they're losing sodium in the urine, they need sodium supplements for a period of time, not only during the NICU stay, but also subsequently following discharge as well. And that is more for the babies who are born between less than 26-27 weeks gestation. Sodium is essential for preterm babies' growth, and for these babies especially, we should try to keep their serum sodium around 140, especially following discharge, because that is important for the growth. And as I explained in the beginning, that the fractional excretion of sodium in extreme preterm babies is very high. So these babies sometimes need up to 10 to 12 MEq per kg per day of oral sodium to maintain their sodium levels. And as they grow older and the renal tubules mature, then that sodium dose is gradually reduced. Not all cases are very straightforward. There will be some cases where the cause may not be very clear. And in those cases, it's important to seek senior advice, and we may need input from our colleagues in pediatric endocrine and pediatric nephrology. And in those cases, we have to look at checking other investigations like fractional excretion of sodium, urine, and plasma osmolarity, and other investigations. But these are the cases where we need input from our other colleagues. Acute symptomatic hyponatremia is when the baby is severely hyponatremic and is having seizures or is very unwell, most likely because of cerebral edema. This is fairly rare condition, I must say. Personally, I don't remember that I have ever given 3% saline so far. Even babies with 115 to 120 of sodium, I didn't come across babies who were fitting. So I have not needed to use 3% saline. But theoretically, yes, if a baby's sodium is less than 120 and the baby is fitting, then that's one of the conditions where you have to correct it with using 3% saline. And the dose is 3 to 5 ml per kilogram over 10 to 15 minutes. And if there's still ongoing seizures, then this dose can be repeated as well. And this will increase the sodium by 2.5 to 4 MEq per liter. I'm not sure how easily 3% saline is available in different hospitals, but this is something which is required in cases of severe hyponatremia, if the baby is unwell and is fitting. Just a couple of slides that how the hyponatremia should be corrected. And as I explained, that the hyponatremia should always be corrected slowly over a period of 24 to 48 hours. This is the formula that is used: weight into 0.6 and desired sodium minus current sodium. Everyone who works with neonates, we all need to know these very basic calculations, that our 0.9% saline that we use, 1 liter is 154 MEq per liter. So 100 ml of normal saline will contain about 15.4 MEqs. The 3% saline is 0.5 MEq per ml. So 100 ml of 3% saline will contain 50 MEq of sodium. So if we take an example of a 3.5 kilogram baby with a sodium of 111, then that's using the formula that I showed on the previous slides, the deficit comes around 50 MEq, and that 50 MEq is equivalent of 320 ml of normal saline, and that should be given over 48 hours along with maintenance fluids. This is for those conditions where we know that the sodium is low because of the baby is losing sodium in the urine or in the stool. In those cases where there is evidence of fluid overload and the treatment is fluid restriction, they shouldn't need sodium supplements unless they have acute symptomatic hyponatremia. As I explained, the hyponatremia, especially if it's severe, should be corrected very slowly over a period of 24 to 48 hours. And the reason being, if we treat it rapidly, then there will be certain changes in the plasma osmolality. And one of the complications of rapid correction in that case is called, previously used to call cerebral pontine melanosis, now called osmotic demyelination syndrome. And that would manifest as irreversible neurological features like dysarthria, confusion, coma, and dysarthria obviously in older children. And that sometimes can present after a few days as well, after the sodium has been corrected. So the key message regarding hyponatremia is that we shouldn't treat the number. You have to look at everything else and try to treat the underlying cause, find out why the sodium is low. Once you treat the underlying cause, that would correct the sodium in most cases. As is explained before, avoid rapid correction. Aim for a correction of 12 MEQ over 24 to 40 over 24 hours period. So that's for hyper and hypo both more or less the same, 12 MEQ in 24 hours. And if the sodium is below 120, seek senior advice in those cases. So before we move on to hypernatremia, I think we probably can take a few questions.
Yes, sir.
So far.
Yes, sir. Here is a few questions. I think 3 questions.
1 minute, Saeed, 1 minute.
Yes, sir.
Yasir, can you go back to your slide, which is showing around 320 ml of the normal saline you give? Yeah. Can you explain this slide again?
जी सर, इसमें ये है कि this is the formula that I showed on the previous slide that is used to correct the sodium. So weight into 0.6.
But the thing is that if a sodium is 111, you want to correct up to 135?
Well, I think the aim is to get it to the safest level, because if you correct it, the idea is not to correct it too quickly. So you can, this is just for example.
Okay, because 320 normal saline is too much, na? That's why I'm saying.
That is over a period of 48 hours.
Yeah, it's still.
But if you increase this number to from 135, say for example, you want to raise it to 1.
No, I want to decrease this number.
Oh, that's you want to decrease this? Okay, that's fine. This is just like just for.
Because we don't correct to 135. If the sodium is less than 120 or less than, then we correct up to 125 or 130 max, and then we will go.
So this was just for just as an example.
Can you explain how to give this along with maintenance fluid? I mean, this should be in addition to the maintenance fluid.
Yeah, well, you will always have to. This is the deficit, so the maintenance fluids will be separate.
Then it's too much fluid. Actually, then you have to have, something hypertonic fluid or something. Okay. I mean, anyway,
this is to be honest, this is not a very common. I've already explained. In most of the time, you treat the underlying cause, and the things will settle by itself. This is just, say for example, you have a baby who has sodium of, say for example, 115. The baby is not seizing, so you don't need to give 3% saline, but so you want, say for example, your baby with the CH, congenital adrenal hyperplasia, 115. So you want to increase it from 115 to, say, as you said, to 125. So
sure.
In that case,
actually,
Sir, as we don't have 3% saline with this, can we dilute normal saline with diluted water to make it half saline by mixing half dilute, half normal saline and half with distilled water?
Well, I have not mentioned half saline anywhere so far.
No, I mean, if we have to give 3% saline, we don't have it. How can we make it?
Well, you have to ask your pharmacist that question. I'm sorry, I don't know how will you make 3% saline.
Okay, thank you.
Yeah, 3% saline is a very difficult to make it, okay, because there is no other fluid available. And what you are saying, you are diluting the Jawad, you are diluting the normal saline further if you add the distilled water.
Sorry, I got it wrong. But people find also
luckily, we have easily available 3% saline, but as I said, I have so far, I mean, in 20 years so far, I have never needed to use 3% saline. I've come across babies with sodium of 115, maybe 116, but have not needed to use hypertonic saline. Most of the time, once you correct the underlying cause, and if you are giving some sodium supplements as shown in this formula, and you raise it to a 125 to 130, then I think you're in the pretty safe zone. So have not needed to use hypertonic saline. But I'm sure if you speak to your, if you have pharmacists in your hospital, if you speak to them, they might be able to help you, because it's not, probably won't, they probably will be able to help that how you can make 3% saline. It's essentially 3 grams of salt in 100 ml, but I don't know how to make it.
Yeah, but this is not an ideal thing, you know. No, it's
I think probably worth speaking to the pharmacist, they might be able to help. Okay, if any more questions so far about hyponatremia?
Yes, sir. Actually, here is a few questions. Two are already answered. One is from Dr. Jawad, and second is from Dr. Naveed Mandurani. Sir is asking 111 sodium should first 120. I think question is I think incomplete. And second question of Dr. Naveed is, isn't newborn having surface area is 70%?
Sorry, I didn't understand. What was the question?
Actually, so question is actually sir, जिस तरह ये आपने जो formula sir share किया ना example वाला के 0.6.
I can explain.
हाँ, it is actually जी sir, sure.
Yeah, so Yasir, this formula, the one you have written like 0.6 into weight into deficit, that is for infant, because the surface area for newborn is 70%. So I think that is for 0.7 into weight into deficit.
Okay. Any other questions?
So second question is, yes, Dr. Sitara, I think Dr. Junaid already gave answer. Question was preterm losses more sodium in urine and stool as compared to term. So can we give sodium in IV fluids on first day of life?
No, because unless the diuresis has started, you don't need to give extra sodium. The babies will lose sodium in the urine only once they've started passing urine, and that usually happens after 24 to 48 hours.
Right, sir. सर एक्चुअली और लास्ट टाइम भी सर जुनैद से मेरा डिस्कशन हुआ था, मेरा पर्सनली भी सर ने जो डिस्कस किया था फ्लूइड इलेक्ट्रोलाइट्स पे, मैंने एक आर्टिकल भी शेयर किया था, सर ने कहा था कि मैं वो जो है देखूंगा, शायद सर ने देखा होगा, तो उसमें मैंने वो शेयर किया था कि जो डे फर्स्ट और से अगर के हम मिनिमम सोडियम अगर के हम दें, क्योंकि द रीजन ऑफ नॉट गिविंग सोडियम एंड 10% ओनली 10% डेक्सट्रोज वाटर इज टू प्रिवेंट फ्रॉम हाइपरनेट्रीमिया, जो आर्टिकल मैं शेयर करूंगा दोबारा उस पे, तो उस पे अभी मुझे खुद मतलब ये है अभी भी जो है ना
उसमें सही, उसमें I think the current practice is still not to give any extra sodium for first 24 to 48 hours. Only once the baby starts diuresis, then only then they will lose sodium in the urine, and that's when you add sodium into the IV fluid. And some people, even these days, some people tend to weight the baby every day only once they've lost about, say, for example, 5% of the body weight, and then only then they start adding the sodium. So there's no rush to add sodium in the first couple of days. I think that's what I know so far. So if there are no more questions,
no, sir, I think we should move forward. Yes, sir.
Okay, so we'll move on to the hypernatremia next. I think probably you've got the flavor so far that we have to look at the underlying cause and treat the underlying cause, and in severe cases we have to intervene fairly promptly, but rapid correction should always be avoided because that has significant risks of complications, and that is true both for hyponatremia and hypernatremia. Sodium more than 145 millimoles per liter, and again, depending upon the levels, can be divided further into mild, moderate, severe, and extreme hypernatremia. Mild probably is the commonest that we all see as neonatologists in newborns. 150 to 160, probably less common that we see in extreme preterm babies, but anything more than 170 is luckily quite rare, although we do come across, and that is the one which has high morbidity, mortality once the sodium starts going above 165 to 170. So just like as we discussed in hyponatremia, when in hyponatremia there are two reasons that why the baby has high sodium. Either they are dehydrated, there's too little water in their body, or the other reason is that there's too much salt on board, and that is cause hyponatremia. So these are the two main underlying etiological reasons for hyponatremia. Whatever is the cause, that would fall into one of these groups. And that's important to categorize because then your management will change accordingly. So in hypernatremia due to too little water in the body where the baby is dehydrated, also called hypernatremic dehydration, the weight will go down. In extreme preterm babies, as I explained in the beginning, because the insensible losses are huge, especially between 23 to 26 weeks gestation. So in the first few days of life, when the skin is very immature, and they can have excessive insensible losses, and that can cause hypernatremia. And if that is not adequately managed with humidity and IV fluids, the sodium will go up fairly significantly. Another common reason in term babies is suboptimal breastfeeding. Usually that can cause hypernatremia, and we do come across sometimes in babies with sodiums up to 160, 170, just because they have been exclusively breastfed and there have not been enough breast milk, or the technique was poor and the baby gradually got dehydrated. Relatively very unusual in bottle-fed babies, but if the baby has any kind of congenital abnormalities which is making bottle feeding difficult, it can be in bottle-fed babies as well. Diabetes insipidus and some forms of congenital diarrhea, where especially some forms of secretory diarrhea where the baby is losing lots and lots of water in the stool. All these conditions will cause dehydration and hypernatremia. The other group where there's too much salt in the body, in these conditions, weight can go up. This is relatively uncommon, but we see this more in extreme preterm babies, especially if they have been given lots and lots of normal saline boluses and sodium bicarbonate boluses, although none of these are recommended these days anymore, especially sodium bicarbonate boluses is almost a complete no-no these days for preterm babies. And sometimes there might be excessive sodium administration along with other medications like heparinase saline, sodium phosphate, and if the drugs or other infusions like inotropes are made in normal saline, there can be a huge amount of sodium going through those infusions as well. So one has to be very careful in terms of that how the infusions are being made, especially if the baby is hypernatremic. Salt poisoning again is unlikely to be seen on the neonatal units, but it can be a cause of hypernatremia in infants and toddlers. There have been some case reports as well. So these are the two main groups. One is where the baby is dehydrated because it's losing water either through the skin or through the urine or through the stool. And the other group is where there's too much sodium on board, more common in extreme preterm babies, and that is usually iatrogenic when most of the infusions are made in normal saline. there have been lots of sodium normal saline and sodium bicarbonate boluses. I think it's very important to understand the pathophysiology and what happens if we treat it very rapidly. And I think this is the diagram which I took from Dr. Naveed's article on hypernatremia, and that very beautifully explains the pathophysiology. So this is the normal state, and the water moves freely between the plasma and the extracellular fluids. Now, what happens if there is dehydration and the sodium goes up, the plasma will become hypertonic. And as I said in the beginning, the water will always move from low osmolarity to high osmolarity. So the water will move out of the cells into the plasma, and that would cause shrinkage of the cells and leading to cerebral thrombosis, bleeding, hemorrhage, and that would manifest clinically with signs of encephalopathy and seizures, unconsciousness, lethargy, feeding difficulties. This is what happens in acute hypernatremia if it goes untreated. And on the top of this picture, it explains that if you treat the hypernatremia relatively quickly, what will happen is that the plasma will become hypotonic, and then the water, say for example, the sodium was 160 and you rapidly correct it to 140, the water then moves from low osmolarity to high osmolarity. It will go into the cells and will cause cerebral edema, and that again would manifest as lethargy, feeding difficulties, unconsciousness, seizures, and in extreme cases can even cause herniation and death. So both ends are fairly have high morbidity and mortality. If the hypernatremia goes untreated, that has got its own complications, and if we correct it rapidly, that has its own complications. So prompt identification and preemption that this baby might develop hypernatremia is very important. And at the same time, if there's a baby who has developed hypernatremia, very slow correction of that sodium levels is important, because rapid correction itself has significant side effects, significant morbidity and mortality. So just like hyponatremia, the clinical assessment for these babies, again, when you look at everything, you look at the gestation, you look at the clinical picture, you look at the clinical examination of the baby, the weight, whether it's going up or down, the urine output, electrolytes. Again, essentially more or less the same things that we talked about regarding hyponatremia. This is something that I think we off and on will come across a term baby who has been sent home, and especially I used to see these cases in the UK as well, but because their babies are get weighed on day 4, day 5 by the community midwives. But in Pakistan, because there is no as such system where the babies are assessed on day 4, day 5 by the midwives, so the mothers will continue to try to establish breastfeeding, which for some reason is not working, and the baby will progressively become dehydrated. And it's only when he's severely unwell, they will be brought to the hospital. So in the last 2 years, I think I've seen about 3 to 4 cases of severe hypernatremia where the sodium was about 170 to 180, with a weight loss of about ranging from 15 to 20%. So not a very uncommon problem in Pakistan, because the monitoring is not that robust as in Western countries. And the other problem is that there are no clear-cut guidelines that once the sodium goes above 160 to 170, how these babies should be managed. So it's a bit difficult as well. I think most of these cases I have discussed with colleagues, and there is no consensus about how these babies should be managed when the sodium goes up so high. So just to give you an idea that once the sodium goes up, say for example, above 155, it can be up to 160, 170, or 180. I think this table is very important when we come across a baby with severe hypernatremia. And this is you can exclude the babies with who are extreme preterm because their management is slightly different. This is for the babies who are dehydrated, like especially the term babies who have been dehydrated due to inadequate breastfeeding. Now you can see that at the sodium, when the sodium is 170, you can see that if you give this baby, as I explained before, we need to give as much possible as isotonic fluids, because if we give hypotonic fluids, that will cause sudden shift of the fluid and that would cause significant cerebral edema. So at the sodium, when the sodium is 170, if you give 1/5 or half normal saline, it is only 46% isotonic at a sodium of 170. So across all these numbers, you can see the only fluid that can be used is 0.9% saline. Although when the sodium goes up to 180, 190, even that is quite hypotonic. So you might wish to increase the concentration of the sodium in the saline somehow to increase the tonicity to match the osmolarity of the plasma. So this table is very important. And I think one of the messages I would like to give from this presentation is that avoid giving, if possible, I'm not saying that do not always use, but avoid using hypotonic fluids when the sodium goes above 150 to 160, because that would cause cerebral edema and the risk of complications is very high. How do we manage if the baby is dehydrated? If there's too little water, you treat the underlying cause. For example, if the baby is extreme preterm and we know that the baby is dehydrated because of the increased insensible fluid losses, then the humidity in the incubator has to be maximized. Now, I know that in Pakistan, because we don't look after 23, 24 weekers very much, and most of the, sometimes the incubators don't really work. We know that there's the humidity in the incubators doesn't always work, but for survival of extreme preterm babies, it's important that the humidity in those incubators is increased up to 70 to 90% to make sure that the insensible fluid losses are reduced. In these babies, the fluid management is very tricky, and it has to be assessed every sort of at least 8 to 12 hourly, and that is guided by especially in the first few days of life, and that is guided by the electrolytes, by the weight and the urine output. For babies who are hyponatremic because of inadequate feeding, they might need extra feeds and extra fluids, and depending upon the degree of hyponatremic dehydration. And as I explained, the hyponatremia should always be corrected slowly over 48 to 72 hours in term babies. Again, just like hyponatremia, we have to calculate the deficit and the maintenance. So if a baby, say for example, has lost about say 500 grams of weight since birth, so that would be the deficit, and you also calculate the maintenance, and then that both deficit and the maintenance is then corrected over 48 to 72 hours. If the sodium is more than 160 to 170, then these are the babies who are really critical, and they might be very unwell at presentation, and they become even more unwell if they're not adequately managed. So they should be in an ICU setting with very close monitoring. And in most of these cases, the fluid of choice when the sodium is so high would be 10% extra with normal saline. And our aim would be that we reduce not more than 12 MEQ per liter in 24 hours. And as I explained before, once the sodium goes above 155, even normal saline, which is 154 MEQ per liter, it will be hypotonic as well. So there are ways. So that's why we should avoid, when the sodium is so high, then avoid using 0.45% saline or anything lower than this. This is I would say a special group of babies when the sodium goes above 160, because they are the ones who are unwell at the time of presentation, and as I said before, if they are not managed properly, and if they are given either wrong fluid or if they are given too much fluid, they can become even more unwell because of the cerebral edema. So I think when managing these babies, very close monitoring is important. They need 4 to 6 hourly sodium measurements, and the fluid should be adjusted accordingly. In all babies where the serum sodium is more than 170 to 180, these cases, the advice should be sought from the senior clinicians. Now, there is a way of increasing the sodium concentration in the fluids, as the normal saline has 154 MEq per liter of sodium, and if we want to make it as close to the plasma sodium, say for example, if the sodium is plasma sodium is 170, and we want to give a solution which has more or less the same sodium concentration, that can be made easily. You can remove you can add 3% hypertonic saline into the 0.9% saline by calculation. So say for example, you want to increase from 154 to 170, that is a difference of 16 MEq. You want to increase it to 16 MEq per liter. So if you add 32 ml of 3% hypertonic saline, so remove 32 ml and add 32 ml of 3% hypertonic saline, that solution will become 170 MEq per liter solution. So these are the, as I said before, there are no consensus guidelines, and some people have recommended using this kind of fluid when managing babies who have very high sodium concentrations. When the sodium goes above to 190 to 100, these are the babies, again, are very rare, but we do come across. I think Vikram had a case of sodium more than 200, as I remember from the academic neonatology group, and these are the cases where I think should be managed with input from peds nephrology, and should be managed very in an intensive care setting, and some of these might need peritoneal dialysis. The extreme preterm babies, as I have explained before as well, they are very high risk for hyponatremia if the humidity is not adequate. So with them, humidity has to be maximized to 80 to 90%. Sometimes they need more fluids, sometimes up to 180 to 200 ml per kg per day. And also, while managing these extreme preterm babies, it's also important to avoid acidosis, avoid giving bicarb, and if possible, using acetate in the TPN to correct acidosis, and that would also correct hyperchloremia as well. So, too much salt, if the baby is not dehydrated but is hypernatremic because they has been given too much salt, and that is usually the case with extreme preterm babies who have been given either normal saline boluses or bicarb boluses, or the infusions have been made up in normal saline. In those preterm units, it's better to avoid unnecessary saline boluses, unnecessary bicarb boluses, and where possible, the infusions should be made either in 0.45% saline or dextrose to avoid the risk of hyponatremia. So the key message is that you look at the changes in weight, look at electrolytes, look at the fluid balance, input, output, and always avoid rapid corrections. And in extreme cases, in severe cases where the sodium is going above 160, 170, seek senior advice early. In difficult cases, paired urinary and plasma electrolytes, paired urine and plasma osmolality, think of endocrine and renal causes, and seek appropriate advice. I think that's the end of my presentation. We'll take any questions, and if there are any questions which people cannot ask now or want to ask, they can email me as well. Thank you.
Thank you so much, sir. Such a wonderful presentation. I think we have one more question. Sarah's question is, any role of anticonvulsant in case of hypo or hyponatremia, especially in seizures?
Yeah, as I explained before, that well, in hyponatremia, unless if there's acute symptomatic hyponatremia and the baby is seizing because of hyponatremia, until you give you correct the sodium, it is the seizure is unlikely to stop. But as I explained, that all these babies at both ends they can have fits because of cerebral edema, they can have seizures because of intracranial bleed, they can have seizures because of cerebral venous sinus thrombosis as well. So in those cases, yes, you'll have to give anticonvulsants as well.
All right, sir. Anyone participants wants to ask the question? क्योंकि यहाँ पे सर फिलहाल ही एक ही क्वेश्चन था इसमें हैपनिट्री वाला. अगर कोई ऑडियंस में से कोई क्वेश्चन पूछना चाहता है तो प्लीज मोस्ट वेलकम. वहीद, डॉक्टर वहीद है हमारे यहाँ पर.
Yes, Saeed or Yasir, somebody asked the question, the effect of maternal drugs on the baby.
Yes, sir. Yes, sir. Yes, sir.
So, Yasir,
जी sir.
okay,
Mother drug intake such as the so question is mother drugs intake such as diuretics, oxytocin, any hypertensive drugs or glucose can cause hyponatremia. So my question is, for how long babies develop hyponatremia?
if it is developed.
Sorry, sir.
अगर वो develop हो due to the effect of the maternal drugs, okay?
जी sir.
Yeah.
I'm not sure, Junaid, I think you might be able to answer this question because I don't know. I think you still have to look at the clinical picture, whether the baby is, if the baby is hyponatremic, why the baby is hyponatremic, and then maybe look at it.
Sure. I think the most of those drugs has not effect or minimal effect, okay, unless until something extraordinary happen or the kidneys are compromised before birth. But of course, we have to do the electrolytes within 24 hours and see. And I think we have to find out other causes other than the maternal drug. Okay,
I think the approach remains more or less the same as in
exactly.
The approach remains the same, that you look at why the sodium is low, what's happening with the weight. I must say it's very rare that the baby would become hyponatremic because of the maternal drugs, unless the baby has any kidney problems. If the kidneys are normal, it's unlikely.
Naveed, do you have any comment? Or sir, Dr. Hafi, if you have any comment on that?
If the mother is given at the time of delivery fluid boluses and the baby might manifest, but we will not treat that.
Yeah.
In the initial 24 hours, and even we don't check the initial electrolytes within 24 hours. So whatever, if for some reason some people do it, don't treat it unless the baby lose weight. We must ensure that the baby lose weight to do the physiological loss.
Exactly. So you have to check after 24 or within 24 hours and then see. Okay, good. Okay.
Sir, एक और क्वेश्चन था मेरा खुद.
Yasir?
सर क्वेश्चन. जी सर.
Doctor, can you hear me?
जी sir, we can hear you, sir.
Okay, so Yasir, my question is that as you rightly mentioned in your presentation, that we come across a reasonable number of newborns, term newborns. They come from home with a sodium of 175 or 180, and there are two strategies. Most people, the clinicians, what they do is they start IV fluids, keep babies in the NICU for a longer time, and then they take time to shift to the mother feed or the formula feed. So my question is that out of these two options, if initially baby is dehydrated, you're given 20 mils per kg of the bolus, and then slowly you've started fluids, baby is getting better, and the sucking is okay. So do you think that the shifting them an oral is better as compared to keeping them IV fluids in our setup? And other thing is that sometimes it is the problem with the mother milk. So baby is already on a preterm formula, and in preterm formula, sodium content is high. So in these cases, when we are shifting on the formula after IV fluid, then whether to give a preterm, or in these cases, we have to give, if mother feed is not available, give term formula with low sodium.
So I think, Sajid, as far as the feeding is concerned, that depends how unwell the baby is. I mean, if the baby sodium is 160, 170, I think probably your first aim is to bring that sodium slowly down, because that baby is likely to be so unwell that he will, even if you give the feed, he probably will not suck. So in the first 24 to 48 hours, you probably will rehydrate, bring that sodium down. And once the sodium is down to, say, for example, 150, and the baby's clinical status has improved, the dehydration has improved, the baby has become normovolemic, then there's no reason why not to feed the baby. And again, if possible, we should try to establish the breastfeeding and provide whatever required support is for the mother, and avoid formula milk if we can. But if there are extreme difficulties in establishing breastfeeding, then obviously you have no choice other than going on to the formula milk. As far as you mentioned about the preterm formula versus term formula, I mean, this kind of hyponatremic dehydration is more common in term babies. We don't see this very often in preterm babies. So I think probably you can easily go with term formula if required. But as I said, we should try our best to get the baby back on breastfeeding rather than the formula feeding.
Okay, thank you.
Anyone else? सर मेरा एक क्वेश्चन था मैं सर एक्चुअली ये था कि नॉर्मली वी ऑलवेज डिस्कस, आपने बताया कि our target is not correct the sodium more than 12 MEQ in 24 hours. But what I have read कि we can, क्योंकि ब्रेन की जो फिजियोलॉजी है it's very different from other part of the body. तो ब्रेन में जो है अगर के acute hypernatremia जो अगर हो रही है तो we can correct 1 MEQ per hour as well. तो उसके बारे में काइंडली आप
नहीं सही इसमें तो as far as my understanding is concerned, I think we are talking about acute hypernatremia जो कि कुछ दिनों में डेवलप होता है, तो उसके अंदर जो रेगुलेटरी मैकेनिज्म्स होते हैं ना, जो एक लॉन्ग स्टैंडिंग हाइपरनेट्रीमिया में डेवलप होते हैं, वो नहीं डेवलप हुए होते. ये दिस इज द पिक्चर जो कि डॉक्टर
हाँ सर, एक्चुअली मैं वो सब मैं शेयर करूंगा. एक्चुअली सर मैंने जो पढ़ा था वो ये पढ़ा था बेसिकली कि जो ब्रेन की जो फिजियोलॉजी है वो ये इस तरह है कि नॉर्मली अगर एक्यूट हाइपरनेट्रीमिया हो रही है तो उस वक्त सडनली जो है ब्रेन सेल्स क्या करते हैं कि वो फ्रॉम एक्स्ट्रा सेलुलर टू इंट्रासेलुलर शिफ्टिंग होती है सोडियम क्लोराइड की, ताकि टू मेंटेन द टोनिसिटी ऑफ द इंट्रासेलुलर फ्लूइड्स. फिर after 4 to 6 years, some iodoosmoles are produced like glycine, taurine, and sorbitol, etc. They play a role in the chronic hyper or hyponatremia. So if we correct acutely, even though book में सर वो जो लिखा था मैंने सोचा कि आपसे डिस्कस कर लूँ कि वो लिखा था even though अगर कि we correct 1 MEQ per hour, it's safe. तो ये बस डिस्कस करना. I will share, sir. I will share the reference as well on group after.
Dr. Naveed अगर है, I think he probably can comment.
I think
as well
Naveed
on
can
this.
answer.
जी सर, जी सर. Sir Naveed, can you hear us?
I think Naveed might not be on, but I think as far as I know, I think the consensus still is to reduce it. But you're right, if it's very acute, but most of the cases that we see probably will be the ones who have been hypernatremic for say 4 or 5 days. So not very acute and not long enough to develop all those regulatory mechanisms that can develop in long-standing hypernatremia. We probably will have to still go very slow.
Right, sir. Right, sir. Thank you, sir. Anyone else wants to ask any question from audience? Dr. Sarish, कोई क्वेश्चन है आपका?
डॉक्टर हक की तरफ से कोई कमेंट, डॉक्टर जुनैद की तरफ से कोई कमेंट?
No, we did in between. It's a very nice presentation and very easy to understand. So I don't think so that we already discussed all these questions.
डॉक्टर जुनैद, आपका क्या एक्सपीरियंस है फॉर अगर सोडियम 180 के साथ एक न्यूनेट आता है से डे 4 डे 5 पे?
Yeah.
So what fluid would you use to start with and to rehydrate in the first 24-48 hours? You say the sodium is 180.
Yes, same. We have to correct the initially and to try to bring it down up to 150.
So कौन सा fluid use करेंगे आप?
We do go sometime. Actually, there is only few cases, 1 or 2 cases like 180 or 170 ke around. So we use half normal saline.
लेकिन हाफ नॉर्मल सलाइन तो हाइपोटोनिक नहीं होगा एज कंपेयर टू, हाफ नॉर्मल सलाइन तो 77 MEQ पर लीटर है.
हाँ,
तो
77 is
हाँ.
hypertonic. That's why we do correction over. I mean, as soon as it is coming down to 160 and this thing, we shift to the normal saline.
हाँ, लेकिन मेरा कहने का मकसद ये सर कि आई थिंक इवन फ्रॉम द बिगिनिंग इट शुड बी यू कैन यूज नॉर्मल सलाइन राइट फ्रॉम द बिगिनिंग एज वेल, क्योंकि अगर 180 का सोडियम है और अगर आप नॉर्मल सलाइन भी
हाँ,
देंगे
वो
तो
डाइल्यूशन होगा उसका, नॉर्मल
हाँ.
सलाइन यूज कर सकते हैं, लेकिन इट डिपेंड्स के हाउ द बेबी इज एक्टिंग. इफ इस 180 पे वो उसको सीजर्स हो रहे हैं, इरिटेट हो रहा है, देन यू हैव टू थिंक अबाउट इट. द प्रॉब्लम इज दैट के you have to correct it a little bit, cautiously but quickly. That's the thing. So it all depends which condition the baby is coming to you. But anyway, if it is more than 155 or like up to 160 or 170, we use normal saline. ये मैंने
Yasir?
जी.
Yeah, ये देखें, ये जो I think the slide which you are showing right now, I think that nicely explains that if the sodium is higher, the fluid selection should be with the higher sodium to have a minimum difference, and number two is the free water content, and free water content in the 0.9% saline is just 4%, and if you compare it with the other fluids, you have got more free water. So higher the sodium, serum sodium, you have to select normal saline to have a less difference between the two sodiums, and moreover to have a less free water content. This is what I understand.
Yes. This is the slide which I showed also. It's from Naveed article also. It showed that it's isotonic, acidity and everything. But the problem is this, that's the same thing. Is free water percentage is a higher in that, okay, and the isotonicity is only 43% as compared to 86%. But the problem is that how fast you want to correct it, the fluid, and then the other thing is that how much fluid you are giving. That's the other thing, total fluid, how much you are giving. Preferably, of course, it's a normal saline, but it also depends that how the baby condition is.
I think उसमें ये है कि you have to obviously calculate the deficit and the maintenance both.
Exactly.
और उन दोनों को फिर आप deficit अब देखें, अगर एक 3 किलो का बच्चा है और वो 2.5 किलो पे आया है, तो that is 500 ml 500 gram weight loss straight away. तो वो तो सीधा 500 ml तो आपका वो deficit ही हो गया. And if you're collecting it over 72 hours, तो आपको 72 hours का फिर maintenance लेवल से calculate करना है. And then you have to उसका hourly rate calculate करें और फिर जो है वो आप I think अभी तक मैंने जो अभी 3-4 केसेस जो 170 से ऊपर के इधर देखे हैं, उधर यूके में तो खैर इतने नहीं देखे थे, वो मैंने यही देखा है कि I think they respond better if you use just simple 10% dextrose with normal saline, और closely monitor करें. और अगर तो आपका सोडियम रैपिडली गिर रहा है, इसका मतलब है कि you are giving too much fluid, और अगर ये बिल्कुल नहीं गिर रहा तो इसका मतलब you are giving less fluid.
Sure, I agree with you. Yeah.
We have always used normal saline to bring the sodium down slowly. The two things are important. One is to bring the sodium down very slowly till it comes to about 150. Then you can change the fluid you're giving. But initially, we have always started with normal saline.
Yes,
and the second point, which was earlier discussed, the effect of maternal drugs on newborn sodium. I've only seen it with chemotherapy. If the mother is on active chemotherapy, then the sodium is maybe significantly affected in the fetus. We worked at Royal Marsden, the main cancer center, and there a number of mothers who were being treated for cancer on chemotherapy, their babies we saw with a significant sodium imbalance.
Sure.
एक चीज और प्रोफेसर खालिद, जो पिछले दिन मैं एक देख रहा था कि कुछ मदर्स जिनको एट द टाइम ऑफ डिलीवरी obstetrics ने अगर बहुत ज़्यादा IV fluids दिए हो ना, say for example if she was unwell for any reason and she received lots and lots of fluid boluses, lots of fluid, वो बच्चे they tend to become hyponatremia because they've got too much water on board as when they're born.
Absolutely right. Absolutely right. The transmission of fluid from the mother to the baby at the time very close to or in the perinatal period is significant, and it affects the fetus quite a lot.
जी.
Thank you. An excellent presentation, Yasir. Excellent. Thank you so much.
Thank you.
Thank you so much, sir. Really, it was very nice presentation. And the most common problem which we are facing on daily basis, I think, those who working in ICU. So it's worth important for us to learn. And inshallah, I hope कि जो भी participant हमारे थे, काफी जो उनकी questions थे, they all learned today from our seniors, from our teachers. And once again, sir, thank you so much, sir, for such a precious time. And again,
just one comment for our younger colleagues. What Yasir showed earlier, the physiology is very important. You need to remember physiology. People tend to remember numbers, but you need to remember physiology. What is causing hypernatremia and what is causing hyponatremia? And you need to treat the physiology. And don't focus so much on numbers, but focus on what is happening to the baby, the physiology of baby, how it has been impaired, and you correct that.
Agreed, sir. And most of times, sir, we